Trying to help some people who can't get in, so hang tight for a sec. Okay, do I have Sally? Oh, there you are. I have Benacar. I have Jack. Chang Wei. Well, we have everybody but 9. That's pretty good. Actually, 8. All right. So let me see some faces so that I'm not the only one with my tired face showing. So what I'm going to do is just review some of the content that we went over. Obviously, I'm not giving you a direct list of what's on the test, but everything that's on the test we will have gone over today. Okay, so what are the main functions of the kidneys? And it's probably easiest if we just do it in the chat. What are the functions of the kidney? Right, filtering, maintaining blood pressure, to pee or not to pee. Yep, that's true. So we've got filtering, but is the kidney's main job to control BP? I mean, it's filtering, but how does the kidney control blood pressure? It controls it because something else impacts it. What other organ affects it? Not the bladder, but a good guess. What sits on top of the kidney? It sits near that. The liver is actually in front of it. Right, the adrenal glands. So the adrenal glands sit on top. The adrenal glands are the piece of that controls blood pressure. So our main one of the main things that it does obviously is filtering, but what did you learn about that we talked about where kidneys fix lungs, lungs fix kidneys? What were we regulating? You had to look at the bicarb, the CO2, and the pH level. Blood gases, right? So part of the kidney's job is to control pH. So we have filtering, we have pH, and then a big thing is getting rid of the waste. But remember, the other piece of waste is maintaining fluid volume. So it inadvertently helps to control our blood pressure, but it can't do that without the presence of what hormone that comes from the adrenal. Aldosterone, very good. Aldosterone. Okay, so how many nephrons do we have? It combines neurotropic B vitamins with a clinically studied amount of ALA, which reduces occasional nerve discomfort in as little as 7 days in your hands and feet. Nervive comes from the makers of the world's #1 nerve care brand. With Nervive, I'm sleeping great. Yep, about 1 million, right? We have 1 million of those. So what is the What part is the beginning of a nephron?
A woman with occasional nerve discomfort doesn't have to. Try Nervive like I did and get your freedom back. Find Nervive at these retailers near you.
Yes, the precise answer would be 1.4. What's the beginning of the nephron?
So I only pay for what I need. Wait, break that. Oh no.
What's the beginning of the nephron? The ball of capillaries, glomerulus, and the glomerulus sits in the Bowman's capsule. Very good. So we have our glomerulus, and then it sits inside of Bowman's capsule. So what is it that, what is the job of your glomerulus? Yeah, it's our first part of filtering. It's the very beginning of any kind of filtering in our lungs. So um, so that's where we start. What leaves? What is the name of the vessel that goes into the glomerulus? Which arteriole? Remember, it's A, because remember, E is exit. So E means exit. So the efferent is going to be what leaves, but the afferent is what comes in. Okay, so so blood comes into there. Why does some of the blood just go into the glomerulus and then just leave the glomerulus? What are the main things being filtered there? Salts is one of them. Sodium is a big one. And the other is blood cells. So your remember, your glomerulus is the beginning of our filtering process. And within that filtering process, we are we need the sodium and some of the other ions as well as blood cells to go back into the blood vessels. So some of it comes in because remember, all of our blood goes through our kidneys every time it goes through the body, every single bit of it. And so it goes through there, makes a pass through there. And if it's something like blood cells or sodium that we need, those just turn around and go back. And then what kind of back on the functions of the kidney, what are the big things that the kidney filters? It's toxins, but what are the toxins? Waste, but what are they specifically? Protein can be one of them. It's really the breakdown of protein, right? So potassium ions are, we need a certain amount, so we need to filter that. But I'm talking about what are waste products. So what is the product of protein breakdown? So yes, it's the amino acid, but what as an amino acid, how do we see it in blood tests? Creatinine is one. Ammonia is another. And the components of the BUN. Very good. It's the urea, so that's the urea, the nitrogen or the nitrogen-based waste products, which is when you said protein, that's correct, but it's the nitrogen from the breakdown of proteins that we lose as a waste product. So the biggies are going to be your creatinine, your urea, and ammonia, because remember, ammonia is not something we can have. If we have too much, like if somebody has liver problems, we end up with too much ammonia and we end up with mental status changes. So we need to get rid of the breakdown of proteins predominantly, and then the extra stuff while we're at it. So, all right, so we leave the glomerulus and we enter what? The proximal tubule. Very good. And what happens in the proximal tubule? And this is where we're going to combine that reabsorption secretion piece. So in the proximal tubule, what's happening there? Gosh, you guys must really want to go over this stuff. Got 25 of you now. Either that or you just wanted to see my face again this week. So what specifically is happening here? Very specific job. I'm not sure what you mean, hi. So its primary job is reabsorption. What is it reabsorbing? So what do we need to keep? Water and ions, right? Water and electrolytes. We've got to hang on to those. So our proximal loop, we are reabsorbing the solutes or the ions predominantly and water. What's happening in the loop of Henle? What's happening in the loop of Henle? Loop of Henle is reabsorbing what? You're right. It's sodium and chloride. Sodium and chloride. So our loop of Henle, its predominant job is sodium and chloride. Okay. What about the distal tubule? We have two things happening here. We have reabsorption, but we also have secretion. In other words, we're sending stuff out and we're reabsorbing things. So we've got two-way motion happening at the distal tubule. So what are we reabsorbing? Yeah, we're still doing water and sodium because remember, my kidney's whole job is making sure I keep my electrolytes. So I'm still messing around with water and electrolytes. But what am I secreting? Secreting being getting rid of. What hormone do you mean? Yeah, potassium, ammonia, creatinine. Aldosterone and ADH kind of has another purpose later on. But the main secretion portion, when you talk about the secretion portion of the kidney, is that it's secreting those waste products, but also the um, the um, the big things like ammonia, the urea, the nitrogen, but also extra potassium, extra sodium. So that's where the secretion comes from. The extra hydrogen. Remember, hydrogen is how we control pH. So when you talked about, um, I think it's because Miss Tina was here earlier. Oh, is there a question? So we get rid of the excess hydrogen, but we forgot one. What about medications? Remember, your kidneys also have to do with filtering out medications. It's a twofold job. We have that with the kidneys, and we have it with the liver, which you'll do in term 3. So when we say it's secreting, so I've got those nephrons. Where do my nephrons sit? Are they in the renal corpuscle or the renal medulla? Where do my nephrons sit? They sit in the medulla. Very good. So they're sitting in the medulla and they're doing some secreting. And so where am I secreting into? Into the renal medulla, right? So my nephrons are hanging down into the renal medulla. And so I'm secreting into the renal medulla, but what specific part? Well, they are mm, tubes of sorts. I'm talking about what's secreting or what's leaving my convoluted tubules. So I'm leaving convoluted tubules. Oh, you're right. They go into the collecting ducts. And then where do the collecting ducts go? To the calyces. Very good. Into the calyces, and then the calyces enter the renal pelvis. Very good. Okay. Ba-dum. What do we find in the renal corpuscle? Not the bladder. What do we find in the renal corpuscle part of the kidney? The capillaries, specifically the glomerulus, the capillaries within the glomerulus. So the corpuscle or cortex, the only part of my nephron or I have a glomerulus and inside of Bowman's capsule that exists in the renal cortex. I have lots of them, but that's where my glomerulus is. Then the tubules are in the renal medulla. The renal medulla, the secretions go into the collecting ducts, and that's where basically the secretions are going to become our urine, that the collecting ducts enter the calyces and the calyces enter the renal pelvis. Okay, all being supplied by um, blood vessels on and to and from the uh, kidney, right? and the inferior vena cava. All right, tell me about the juxtaglomerular apparatus. What does it do? Or first of all, what is it? The distal tubule, the secretion that's where specifically when we talk about the secretion piece, it's excess hydrogen, it is the ammonia, it's the urea, it's the excess sodium, the excess potassium, excess water, and all of that is going to make up our urine. And so if you think about what we look for in a healthy urine versus a non-healthy urine, right? Um, uh, the excesses are going to go out in the urine. Okay, so it's all those things that we were talking about leaving the kidney. That's how it does it. The tubule itself doesn't control BP. It controls water in the that's either being reabsorbed or excreted, and depending on how much it hangs on to, will inadvertently change the volume, but that's because of renin. That answer your question? Okay, so the juxtaglomerular apparatus is a group of specialized cells. Okay, they're specialized cells. And what do those specialized cells do? Oh, I see. I had some answers in here that answered my question on the juxtaglomerular, and some that were answering questions to the question that was posed up here. Okay, so let me back up so you don't get confused. So, in terms of secretion, secretion is going to be all of those waste products that you know to be true of the kidney, the BUN, the urea, or the blood urea nitrogen, which is basically your urea nitrogenous waste, blood cells, but very little, your ammonia, your excess hydrogen, because again, that's how we control blood pressure or how we control pH is how much hydrogen we keep on board. pH is the percent of hydrogen, in case you didn't know that. It's the percent of hydrogen. So how much hydrogen we have floating around determines our pH. So we give and take hydrogen in order to control the pH of the blood. And so all of those things leave through secretion of that distal tubule. So then my question was, our juxtaglomerular apparatus, and the answer got mixed in here with people answering the other question. So the juxtaglomerular apparatus is the specialized cells, and yes, they do regulate what the kidney's doing, and in regulating what the kidney's doing, they are because they're regulating what the kidney's doing, then a roundabout way they are controlling blood pressure, right? Because based on what the nephron does, it controls the blood pressure, but it can only do that through that release of renin. Okay, so if we have a non-functioning kidney, I may want to do that, but it's not going to be able to do that. So it helps with blood flow. It helps with glomerular filtration. So it helps determine the glomerular filtration. And it controls that blood pressure and filtrate. Okay, so the actual part that controls blood pressure is not exactly the nephron, it's actually the juxtaglomerular apparatus, because when it basically doesn't have enough stretch, it will release renin, and in doing that, you start that renin angiotensinogen cascade to raise the blood pressure. Okay. And remember, the juxtaglomerular apparatus is predominantly for decreases in blood pressure. Its job is really to raise the blood pressure by secreting renin. Okay. So that's its main purpose. So what is the renin angiotensin aldosterone system? So renin is released, and then what happens when renin is released? It goes and talks to what? The first A. Angiotensin 1, right. So renin is released. It says release some angiotensin 1. And then if I have the catalyst, which is what? What do I need in order for angiotensin 1 to become angiotensin 2? Angiotensinogen. Angiotensinogen. So angiotensin 1 becomes angiotensin 2 if angiotensinogen is present. Okay. And once that happens, angiotensin 2 does what? Causes the release of what hormone? From the adrenal cortex. We talked about it earlier. Another A. Aldosterone. Very good. Aldosterone. So now we release aldosterone. And when aldosterone happens, then what happens? Do we retain water or get rid of it? What does Al want to do? Retain. Right. So Al likes to retain, Angie likes to tense. So angiotensin 2, as long as it's present, angiotensin 2 is going to raise the blood pressure because Angie is tense, so she vasoconstricts, up goes the pressure. Al, um, uh, so angiotensin causes vasoconstriction of the vessels, and vasoconstriction of the vessels also raises the blood pressure. So a couple of things are happening in that RAS system, right? Angiotensin 1 becomes angiotensin 2, and angiotensin 2 causes the release of aldosterone, which makes us retain water. So we've got two things happening. We're upping the volume, but we're also constricting the blood vessels. And it's that constriction of the blood vessels that makes the blood pressure even higher, and puts the stress on our other body organs like the heart. And as we talked about in the heart, then the heart actually enlarges, right? So next we leave that renal pelvis and we enter what? We leave the calyces. We went to the renal pelvis. Now where? The ureters, right. We have a right and a left ureter. So now we're in the ureter. And what's the ureter's job? Yep. They just transport urine from the kidney to the bladder. That's their claim to fame. The only thing that, they don't usually have too much, Al likes to retain water. Angie likes to vasoconstrict. So Angie's the vasoconstrictor, Al is the volume. So you basically have two problems. You've got an increase in fluid volume, but you've also got constriction of the blood vessels, which is why it's such a that's why ACE inhibitors are so good at what they do. When it comes to the damage that happens with high blood pressure, all the damage to the vessels, to the heart muscle in terms of hypertrophy, all of that is a result of angiotensin 2. It's that vasoconstriction which raises the pressure. And so if it wasn't enough to have extra volume, now we've got decreased lumen to the vessel. And so the damage comes from angiotensin 2. That's why we want to do one of two things to interrupt it. Yes, it all happens at once. So we want to do one of two things to interrupt it. We want to stop angiotensin 1 from becoming angiotensin 2 so that angiotensin 2 just isn't produced. And so we don't get the damage to the vessels and so forth. Or if it gets to if it becomes angiotensin 2, then we want to stop it from raising the aldosterone level to retain fluid. So that's where your ARBs work. Your ARBs stop Al from retaining fluid. Your ACEs stop Angie from raising the pressure, from vasoconstricting. What's your bladder's job? To pee. Yep, that's it. It's just to store pee. What stops reflux? The sphincters and what muscle? The trigone. Very good. The trigone is basically the connection between two ureters and the urethra. Those 3 points, there's muscle in between. And when the bladder is full, it pushes down on the ureters to effectively close them. And that's also the muscle of how we pee. How much pee do we hold? 750 to 1,000. When do we get a message? About 200. Very good. What's the urethra? Yeah, connects the bladder to the outside, right? It's the bladder to the outside. So ureter is from kidney to bladder. Urethra is exit. Okay. What does a BUN tell us? What's it for? Kidney function. Very good. Tells us about kidney function. If it's elevated, what does it tell us? Poor kidneys. What else? Dehydration. Very good. So kidney function, an elevated BUN tells us they've got kidney problems, or that they're dehydrated. And what kind of diet would cause an elevated BUN? Not high salt. That would cause high fluid volume, high protein. Yeah, high protein. Remember, the main components of our waste product is the breakdown of protein. Remember, our whole body functions on building up and breaking down, build up, break down, build up, break down, all fundamentally based on protein. And so, too much protein, you're going to see an elevated BUN. What does a creatinine clearance tell us? If it's high, what does it tell us? Hi, Carrie. What does a high creatinine clearance tell us? It is part of muscle waste, which means it tells us renal disease. Very good. What's a PSA tell us? Prostatic specific antigen. When will that be high? Prostate issues. Right. Are they all bad? What are the two main things it measures? Not renal. Think about what it's called, a prostatic specific antigen. Inflammation of the prostate and prostate cancer. Tells us prostate cancer. Urine osmolality, is specific gravity. Okay. What does a KUB tell us? What does a KUB tell us? Images of the kidney, right. Can only tell us location, size, not much else, unless we have something like stones or something that are, made up of calcium or something that we can see. So most of the time it's just for structure, placement, size. Okay. What's an intravenous pyelogram for? Intravenous. Pyelo means, what does pyelo mean? Dye is inserted so that we can see the flow in the, yes, it's for stones. So it's dye injected. Pyelo means kidney. So it's looking at the kidney. So we're injecting dye into a vessel, and then we're going to watch what happens when it goes through the kidney. Anything that says pyelo means kidney. So it means we're looking at the kidney. Okay. So basically we inject the dye and then we do a KUB so that we can see what we did with it. And of course, it can tell us most of the things we talked about this week. can tell us if the kidney's functioning, because if the dye doesn't go through it, then the kidney's not working. If you see stones, or if you can see, basic function of the kidney. What kind of test do you need to verify that the patient's not having? Because if we do, what kind of test can they not have for before a IVP? Barium, right? Barium. If they're going to have a barium test, we got to do the IVP first, because barium will basically block what we're going to see. What do we need to check for before they get a IVP? Iodine and shellfish, and what other thing do we need to know? Kidney function. Very good. I don't want to be giving anybody any contrast dye if I don't know their kidneys work. And of course, what are they going to feel when they inject the dye? Not a stinging, a warmth. Yeah. They're going to feel a warm sensation and like they have to pee. So they're going to literally inject it in their arm and they're going to go, I feel like I have to pee. And it's just something that happens when you inject the dye. And they get a metallic taste. What do I need to make sure they do after the test? Yeah, drink water and pee. That's true for most everything, right? When in doubt, the answer is always make sure they drink 8 to 10 glasses of water a day, so that we keep the kidneys working. What's a retrograde pyelogram? Yeah, we look at the lower portion of the tract, um, potentially, but then what do? We do a cystoscope to look at the lower part, but then what do? Because remember, it says pyelogram. And it says retrograde. So retrograde means against the urine. So remember, I do the cystoscope and then I pass a catheter up the urethra into the bladder and then into the, I inject the dye into the ureter. So I actually feed a catheter from the urethra all the way up to the ureter and then push dye directly into the kidney. So it's another way at looking at the kidney. But it lets us collect a urine specimen directly from inside the kidney if we want to get something really specific. And because it's, we're doing dye, the same rules apply. Still need to know allergies. I still need baseline. I still need baseline kidney function. And oftentimes they have them, they actually have them do an enema before. This would be more effective because in this case, I am doing a straight shot. I'm literally in the ureter pushing it up into the kidney. So it's a much better test, but much more invasive. So much more visualization, but in some cases they actually do general anesthesia for a retrograde pyelogram. But the reality is most of it, we don't do general for anything. We don't have to. So likely it'll just be that injection of lidocaine into the urethra, and then they feed it up. So generally, if they leave a catheter in, they'll likely keep them overnight. But if they don't leave a catheter, then they'll likely just make sure they can void. What might be normal in their urine after an IVP? A little bit of blood, a little bit of blood tinge, little bit of blood tinge. Yeah, this is not the blue dye. The blue dye that we talked about, the blue dye is when you're mapping lymph nodes, is when you'll see blue pee. In this case, because I inserted something all the way up the urinary tract, remember the whole tract is lined with mucous membranes, and below every mucous membrane is a capillary. So if I'm shoving in a cystoscope and then I'm putting in a catheter behind that all the way up in the ureter, I might have a little bit of blood tinged to the urine, but it should not be, it shouldn't be a lot. And I need to look at urine output, of course, because anytime I inject dye, I always have to ask myself, is my kidney still um, working? Um, any amount of blood in the urine is called hematuria. It doesn't matter whether it's a little or a lot. Okay, what's avoiding cystourethrogram? Nothing here is cyanotic. Okay, so avoiding cystourethrogram is what? Yep, peeing while the test is happening. So we're looking at the bladder and the urethra. In this case, now we're putting in that Foley catheter and injecting dye into the lower part. So a cystourethrogram, remember, anytime you see cyst, CYST, that means bladder. So a urethro being urethra, gram. So we're looking at the bladder and the urethra. So we insert a catheter, inject dye, and take pictures that way. Okay. And it can identify abnormalities or perhaps reflux if that's occurring. Okay. Biggest problem is it's embarrassing. Cystoscope is very similar. The cystoscope, again, topical anesthesia to the urethra. We're putting a rigid scope into the bladder. But in this case, what do I do to improve visualization? They put water. Yep, there you go. Continuous fluid into the bladder. So, biggest problem with cystoscope is it's uncomfortable. There's a lot of pressure, especially since they've got continuous water running while they're doing it. So it's a full feeling, so it's not very comfortable. But then they can see the actual inside of the bladder, looking for things like interstitial cystitis and things like that. So again, as with any test that we put something up the urinary tract, we may see blood tinged urine, but should not see big clots. What is a renal angiogram? Angiogram is looking at vessels, right? Inject dye into the arteries to look at blood vessels. So in this case, again, we're looking at the structures of the kidney, seeing how the blood flow is. Yeah, it's exactly that. It's an angiogram of the kidneys. Same thing as what we do to the heart. We're just looking at the kidneys. And then if we're going to do an angiogram, we enter an artery. If we're going to do a venogram, we enter a vein. What's the post-procedure care on an angiogram? Sandbag to the groin to make sure it quits bleeding and lay flat for multiple hours. How often do we check vital signs after a procedure like this? Every 15 minutes times 2 hours, and then no, usually the protocol is if the every 15 minutes for 2 hours is good, then it's every 2 hours. Good, Michaela. All right, and the only difference in the venogram is that they don't have to do the whole lay flat and put pressure. And in this case, we're going in the femoral vein, not the femoral artery. And as I told you in class, a big part of LVN job is going to be pre-procedure prep and post-procedure care. But a lot of these have the same prep and the same post. CTs and MRIs you knew before you got here. So we'll skip that. What about a renal scan? What's different with a renal scan? Gosh, we're doing a review for your next exam. So the renal scan is the radionuclide tracer. Radionuclide tracer. So in this case, the dye we give them, we don't give them a dye, we actually give them a radioactive tracer. So it's a substance that the substance has radiation attached to it. So we give them that and then take pictures to see where did they go. And different radionuclide tracers have an affinity or have a desire to go certain places, and so we can see what the body does with it. So transrectal ultrasound goes without saying. We're doing it. We're doing a digital ultrasound or through the rectum. It's very uncomfortable. They need to follow instructions as far as holding their breath and so forth so that they get the best picture of the rectal ultrasound. And what does the rectal ultrasound allow us to look at? The prostate. Very good. Let's just look at the prostate. And post-procedure, yep, it lets us look at the kidney too. Sounds bizarre, but it does. It gives us a better shot at the kidney than going through the adipose tissue in some patients. Again, blood tinged urine may be seen because we are doing a digital exam, and sometimes when we're manipulating structures in there with the ultrasound device, they might see blood tinged sputum. Even though they're not putting it directly into the bladder, they're pushing on bladder structures. And so it's possible that they may see some blood from that. Renal biopsy is just what it says. They're going to biopsy it. After a renal biopsy, it's 24 hours of bed rest and 24 hours of bathroom privileges. and they lie on the affected side for 30 minutes with a pillow or sandbag. And that's because sometimes when we lay on our side, our whole side doesn't have pressure on the bed. And so they put a pillow or a sandbag to make sure that the body has contact with a hard surface, to help try to stop the bleeding. Okay. All of these tests, you want to make sure they keep drinking. And remember, with every test, anytime I stick something inside somebody, it's not just this unit, it's everything. Anytime we stick something in somebody, there's an opening into somebody, there's a wound. We always worry about what? Infection. All right. Urodynamic studies, we kind of talked about that already. It's another test where they pee into the cup. Nutrition, I'll let you look at it yourself. But just remember, do we want for people with urine? No, there will not be end-stage renal disease on the quiz. The quiz won't have anything that we have not talked about so far. Okay, so for urinary tract stuff, do we want acid ash or acid alkaline? Do we want our urine acidic or basic? Acid ash, very good. And that includes things like meats, whole grains, eggs, cheese, cranberries, prunes, and plums. And of course, alkaline ash is everything but that. Cranberries, prunes, and plums. Do we want a high protein, low protein diet for somebody who has kidney problems? Depends on their kidney function. Depends on their kidney function. If their kidney function is really high, then I don't want that, because high protein means more waste, which means my kidney has to work harder. And if my kidney's already working hard, to keep up with just my normal stuff, I have to cut down what I give it, not add to it. Okay. But the predominant thing is that we're getting rid of there won't be any questions about Turk because we haven't covered it yet. We talked about that. Make sure you know what is normal and abnormal in urine. And that's just stuff. Okay, what happens to the kidneys as we age? They have loss of function. Yeah, they have loss of function because they can't filter. They can't filter. So they lose about 50% by the age of 70. That's where your 70 came from, Michaela. So they lose 50% by age of 70. They may have some incontinence, but what's the incontinence from? Muscle tone. Muscle tone. So it's that last loss of tone means that they can't hold that sphincter closed. Okay. And then they have incomplete emptying. Are they better or worse at getting rid of waste products? Worse. Yeah, they can't get rid of their waste products very well. Do they like to drink a lot of water? No, which is another problem. So when we talk about all these things, we talked about some of the psychosocial issues. So body image is one. So give me an example of how body image is impacted. Embarrassed. Yep, that's a biggie. Are we going to feel good about ourselves if we can't toilet like normal people? No. We have problems with body image, have problems with anxiety. What if I have an accident while I'm in public? And if you have to, catheterize and so forth, then you have to plan your life around needing to catheterize yourself. So, if this is like, for example, if this is a spinal cord patient, and all of a sudden you're like, oh yeah, and or now they realize they can't pee. Why is it that they just keep asking the same questions over and over and over? Yeah, disappointment, right? Hoping the outcome would be different, but a piece of that is just disbelief, right? How did this happen? Why is this happening to me? So it's that despair and that just being worried about, the consequences and so forth. What do we need to make sure we teach people when we give them an antibiotic when they have a problem? Independence is another one. What do we need to teach them with antibiotics? Take it all. Yep, take the whole thing. Whether they feel better or not. What else? Take it at the same time, right? Keep the blood level up. Drink water. Very good. If I'm taking antibiotics, it means something's wrong in my urinary tract. And so I need to make sure that I'm trying to help flush out whatever's in there. But do I want to start taking a medication and then decrease my water content? No, because then my kidneys can be damaged. What do I need to do before I start the antibiotic? Urine culture, very good. We always culture before we start the antibiotic. So if there's an order for a culture, you got to do that before they take a dose. Otherwise, the culture is not accurate. What else? Allergies. Allergies. Okay. That's not on there. What are some causes of urinary retention? I don't need to check kidney functions before I give the antibiotics as a routine, um, but I do need to check for allergies. Stress can cause urinary retention. Obstruction, yep. Any kind of infection. You can't go. Yep, prostate enlargement is a biggie. Your post-op patient. So lots of potential causes. So how do I know they're retaining? What am I going to assess? They're going to have a distended bladder. Yeah, distended bladder, inability to void or voiding very little, right? And so, how do I treat urinary retention? Depends on the cause, right? Depends on the cause. Sometimes a schedule helps. If this is because this is a Alzheimer's patient that's not remembering to pee, sometimes we can do that. We can do a UA to make sure it's not an infection. Certainly need to check and make sure that they don't have lousy kidneys and that it's because their kidneys aren't working. Spinal fluid's not going to help us with urinary retention. But checking the urine for abnormal sediment or you know white cells, red cells, all of that can give me a clue on what's happening farther up. But anything that affects the kidney could impact my output. But things also like your elderly patient with dementia, they just don't remember to pee. So, but oftentimes they have the same symptoms as if they have a UTI. And so we've always got to, it's all about rule in, rule out, whatever we're looking at. What nursing interventions do we do for a patient with retention? Besides perform a UA? Bladder training. Yep. Train them to go to the bathroom. What if they can't pee? Put in a Foley, but not until what happens? We do the bladder training. We try to increase fluids. We try to warm the perineum or use a sitz bath for comfort to try to make sure that we've tried all of the non-pharmacologic methods before we do things like put in catheters and things like that. And of course, trying to let them pee in the way that we normally pee. So if it's a male standing up or a female sitting down, and then always remember to talk about protective undergarments. And I really was serious. Make sure that you do look at that the next time you're in the pharmacy for that. What causes stress incontinence? Causes stress incontinence. What puts stress on the bladder? Holding your pee can, pregnancy can. Medications are not some of the big ones. Well, remember, we're talking about incontinence. So what would make it so that I can't hold my pee? Pregnancy is one. What else causes pressure on my bladder? A UTI is possible. But the biggies are in anything that increases intra-abdominal pressure, right? I cough, I sneeze, I jog, I lift something. Any of those things are going to stress. Basically, I increase intra-abdominal pressure when I do those things. And when I increase the pressure in the abdomen, it pushes down on the bladder and makes you pee. So that's what stress incontinence is. And what's the main way we treat it? Kegels, right. That's the main one. What's urge incontinence? Could be spasms. Yep. Having to go right away. Yep. Gotta go when you gotta go. That's what urge incontinence is. So what do we do to fix it? We either treat an infection. Sometimes it's increased fluid. And remember, when we increase fluids, we decrease the concentration of stuff in the urine, right? We decrease that change in the concentration of the urine, especially when they have an infection. Um, uh, Bladder training helps because then if you toilet on a schedule, then you can prevent that. But you've got to be on a be able to, sometimes they have to self calf if they have urge incontinence and they can't control it. That's an option. And then we have that drug oxybutynin. Oxybutynin is a drug that we can use. Overflow incontinence is just what it says. Too much urine in the bladder and it overflows. And functional is simply something is not allowing me to toilet normally. So functional incontinence is either because I'm mentally not paying attention to my urge to pee, or I physically am paying attention, but I just can't get there. So somebody who had a hip replacement, somebody who had arthritis, anything like that. And of course, to treat incontinence, we have to treat the problem. We have to treat the problem. So that could be timing, that could be bladder training, that could be Eagles. So depending on the cause. Neurogenic bladder is not on there. Okay, what's common to all the urinary tract infections? The cub. E. coli is the most common germ, yes. But what signs and symptoms do we see across the board with these? Could see elevated white blood cell, burning, frequency, dysuria, pain. So that's the biggies. You know, you can get them from lots of things. It can be from having somebody confused, can potentially, because they're not peeing. So they're confused, they have urinary retention, and the urinary retention leads to UTI. So we also have, using a diaphragm, because that puts undue pressure on the bladder. Condoms can cause it. Immobility can cause it. So the big thing with our urinary tract infections is really where they are and how we treat them. So we talked about urethritis being inflammation of the urethra. Macrobid is a common drug that we give for them. So macrobid is a possibility. Urethritis is where you have an infection in the urethra itself. What are most of those caused by? Most common germs here. The STDs. Our urethritis is most often caused by STDs. And what sets it apart from the others is that you generally have pus and stuff coming out of the meatus. So people who have urethritis always show up at the doctor, because the minute pus is coming out of your private parts, everybody goes to the doctor. Some are asymptomatic. Women may actually not really equate it to the urethra. They may just have vaginal irritation or discharge, and they think it's a yeast infection, but it's actually in the urethra. So if I'm going to collect a urine specimen, what's the most common way to collect a urine specimen? Yeah, clean catch. So clean catch, I have them pee, stop. Well, I have them clean themselves to start with, then I have them pee a little, then pee in the cup, and then finish peeing in the toilet, so that I get the most accurate reading on the urine. And then back to the same things we've already talked about. Increase fluids, take your antibiotics as prescribed, sitz baths for comfort, keep the perineum clean, things like that. And of course, if it's STD based, then, use protection. What is cystitis? What is cystitis? What does cyst mean? Yeah, it's bladder inflammation. Bladder inflammation. Now, does cystitis usually have bacteria or no bacteria? Bacteria, yeah. Cystitis is where we see bacteria. Interstitial cystitis, we do not see bacteria. That's their big difference. So, and again, most commonly E. coli. Why are women more susceptible to bladder infections? Doesn't matter if you're a baby or an adult. Why are women more susceptible to bladder infections? Yeah, it's simply anatomical. The urethra is just shorter. And what are the common signs and symptoms? Same thing, right? Pain on urination, might have blood in it, might have white blood cells, could have pus in it, depending on how bad the infection is. Having to pee at night. What is one of the ways that we often pick up bladder infections on our older, or either bladder infections or yeah, basically bladder infections? What's the most common way we pick up on that in our incontinent patient? Well, that's why they get it, Elizabeth, sitting too long in their feces. That's why they get it. But what's one of the easiest ways for us to know? White blood cells, yeah, they'll have those, but we often know before we ever get there. The smell, very good, it's the smell. We can tell by the odor of either the urine or their diaper that foul-smelling urine is usually an infection. Again, still back to the clean catch, we can certainly look at it under the microscope, and the treatment is the same. What's the length of time we treat UTIs? 3 days, and then what do we do? Retest. Very good. I treat them for 3 days, and then I do a new culture and sensitivity. And same old thing. Force fluids, 8 to 10 glasses a day, unless they have congestive heart failure or something like that. We still want an acid ash diet. What are some non-pharmacologic things that we can have people do for cystitis? What kind of juice? Cranberry juice. Very good. Cranberry juice. And there is a teaching box in your book, so make sure you look at that. What causes interstitial cystitis? It does have to do with holding pee, kind of. Where are we holding the pee? Remember, interstitial. Interstitial means, inter means in, there you go, the inner wall. Interstitial is in the wall. So the urine gets into the wall of the bladder. So is my urinalysis going to show white blood cells? Is it going to show white blood cells in the pee? No, because there's urine inside the wall. My inflammatory response is not being caused by a germ. So my white blood cells will not be elevated. Okay. So I've got inflammation of the um, cells and the mucous membranes, and then so they can have blood in their urine, but they're not really going to have white blood cells because it's not an infection. Usually called, they're usually treated for everything but interstitial cystitis, but unfortunately, there's not a lot of treatment. All right, so we are over an hour and a half now. Um, as far as what disorders are on it, I've pretty much given them all to you. Okay. Do you have any specific questions? Because we've gone over a laundry list of stuff. So, Oh, we didn't talk about things like tubes. Remember, as you go through the rest of this disorders, remember they all have similar profiles for, symptoms. We always want to force fluids, and a lot of that doesn't change. So as you're studying, look for, what makes things similar, what makes them different. But also remember some of this you learned before, like when somebody has a Foley catheter, what's your nursing responsibility? Um, and then compare that to the other things. So, for example, um, what are the nursing responsibilities for you? There'll be 25 questions. What are the nursing responsibilities for you if somebody has a Foley catheter? Flush it if it's ordered. Yep. What else? Make sure it's patent. Absolutely. Skin integrity is a biggie. Don't forget perineal care. Got to make sure that we're not, everything has to be kept clean. Your bag has to be lower than whatever I'm collecting. So when we added new tubes, we talked about several tubes. We watched for very good signs and symptoms of infection. So whether it's a Foley catheter, whether it's a nephrostomy tube, whether it's a um, um, wherever I put a tube in the body, and in this case, we're just talking about urine tubes, wherever I put those, I have to make sure that they're secure, that they're draining, that they're below the level of what I'm draining, that I'm keeping them clean, that I'm keeping a dressing on if it's supposed to have one. And I always got to remember if I put something in, I run the risk of infection. So, as you're studying for this, as well as everything else you're going to do, um, you've got to start piecing things together about the hows and whys. What makes all of these things similar? And then what specifically makes them different? Okay. Let's see if there's anything else. Make sure you review urolithiasis. There's a few questions on that, which is stones in the urinary tract. Okay. Any other questions? I'm impressed that 25 of you showed up. Let me see, make sure I have everybody. I have Alyssa, Elizabeth, Joanna, Knock, Shay, Raiden, Wendy, Zachary, Destiny, Sally, Katie, Kendra, Zachary, Patricia, Lori, Sally, Benakar, Jack, Shang Wei, Michaela, Mojabang, Noemi, Esmeralda, Marissa, and Carrie. Did I miss anybody? Oh, who did I miss? Did I miss anybody? I kept having somebody, Sally, trying to log in. No, there's 25 questions. Oh, somebody named Sally kept trying to log in. All right. Have a great night. I'll see you on Monday. If you get stuck,